My name is Andy Jones. I'm the CEO of Ramsey here in the UK. Ramsey Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly we look after over 8 million patients a year. Ramsey Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsey hospitals to refer their patients for high quality healthcare. So Ramsey has got a long-standing set of values called the Ramsey Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsey Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsey, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.
Good evening, everybody, and welcome to tonight's BOFAS Lecture of Distinction, sponsored by Ramsey Health very kindly. Tonight's talk is on the Liz Franc injuries of the foot. First of all, a couple of housekeeping things. Your certificates for the attending this lecture will be available at the end, and you'll see a feedback code put into the chat function of Zoom about halfway through the lecture, which you can then use when you use your email link to give feedback in order to get your certificate. The other way is at the end of the lecture, there'll be a QR code displayed on the screen, and that again will take you through to the feedback in order to get your certificates. The lecture tonight is about Liz Franc injuries, and it's a really devastating injury at times, and when not recognised or not managed properly, it can be really difficult for patients to live with. And it's really, therefore, with great pleasure that I'm able to invite our tonight's speaker, Adrian Hughes. Adrian Hughes is a consultant at the Royal Devon and Exeter Hospital, specialising in foot and ankle and trauma, having done specialist fellowships both in the UK, South Africa, America, and even Australia before taking up his post. So shortly we're going to hear from him with the Liz Franc injuries of the foot. During the lecture and towards the end, we're going to do some cases, but also there is a chance to ask questions. So please, if you can, use the Q&A icon at the bottom of your screen in order to ask those questions, and I'll then pose them to Adrian as we go through the talk. So without further ado, I'd like to hand over to tonight's lecture of distinction to Mr. Adrian Hughes. Thank you, Adrian.
Thanks very much, Tim. Can you hear me and can you see my first slide?
We can hear you loud and clear and see your first slide. Thank you, Adrian.
Excellent. I'd like to thank BOFAS for asking me to do this. It's a great honour, and I'll try to give value. We've got a half-hour chit-chat about Liz Franc injuries. I'm going to start by introducing the team that I work with. This is a photo taken a couple of years ago. In the centre there is Paul Didd, and he was our fellow. He's now a consultant in Leeds. I hope you can see the arrow there. That's myself. There's obviously a funny joke going on. This is my senior colleague, Ian Sharp, Nick Talbot, and Will Reeve joined us a couple of years ago. On the left there is our surgical practitioner. And I really want to illustrate that we work, no man is an island, we work together. We discuss cases, we discuss literature, we discuss current management, and this applies very strongly to the Lisfranc injury. It's one of the most challenging injuries that we manage, and we discuss every single midfoot injury that we either treat conservatively or take to theatre, and make sure that we have a consensus view. We don't always agree, but we reach a consensus view of treatment. The anatomy is complex, difficult to visualize, and these injuries are uncommon. I mean, that's figures from a textbook. We looked at our last year of fracture clinics, and we review and assess between 100 and 150 midfoot injuries, potential Lisfranc injuries. We operatively manage around 20. So the four of us are operatively managing around 5 each a year. They're challenging for apart from the reasons of anatomy, but the outcomes are not always satisfactory, not always predictable either. They have devastating long-term consequences. There are several studies looking at polytrauma patients. If you have a neglected or missed Lisfranc injury, that's what defines your outcome from polytrauma compared to those that were either not missed or didn't have a midfoot injury. This is Jacques Lisfranc de Saint-Martin. I haven't said that as well as James Ritchie, but he was a Parisian gynecologist. He pioneered the use of the lithotomy position in women's surgery. He was a pioneer in rectal surgery, and unfortunately he was drafted into Napoleon's army, and he served on the Eastern Front. He was presented with a lot of cold injuries and forefoot gangrene, and he became an expert in amputations of this area, describing in the paper the Chopard amputation. And he also was rather observant, and when cavalrymen fell from their horses, their feet were caught in the stirrup and their weight applied to the midfoot in the wrong way, they had an injury to the Lisfranc joints. These are terminal Lisfranc joints after him, and the ligament, the crucial ligament within the midfoot, is attributed his name. So the Lisfranc joints are the tarsometatarsal joints 1 to 5. It's the rigid, I put rigid in quotes, as some of it's more mobile than others, but the rigid, relatively rigid midfoot link between the Chopard joint and the flexible midfoot, flexible forefoot, sorry. The stability comes from the bony structure and ligaments. In the peculiarity of the Lisfranc is it has very little bony stability. It's very much reliant on the ligaments. Knowledge of the bony anatomy is important to analyze and assess X-rays, MRIs, CT scans, the investigations for diagnosis, but it's also relevant in terms of the direct application to reducing these fractures and fixing them. Every time I fix a Lisfranc joint, I get a hold of my bony model and have a look at the shape of the bones, the morphology of the cuneiforms, and how they interact with the metatarsal bases. Key points: metatarsals 2 and 3 are wedge-shaped. They form a keystone with the transverse arch, and the second metatarsal base is recessed between the cuneiforms, something that's responsible for often being fractures seen at the base of the second metatarsal as part of this injury complex. Just to repeat, there is little inherent stability from the bony shape. The stability is really reliant on the ligamentous structures. So looking at those ligaments, the dorsal view on the left, the plantar view on the right, it's obvious that the dorsal view, although these are not cadaveric specimens, obviously the dorsal ligaments are less substantial than the plantar ligaments. a fact that is probably responsible for the failure mechanism of the Lisfranc in a plantar flexion abnormal moment. There are metatarsal ligaments between the metatarsal bases. There is no direct connection between the base of the first and the base of the second metatarsal. This connection is via the Lisfranc ligament that connects the base of the second to the medial cuneiform, and then via the dorsal tarsometatarsal ligament of the first tarsometatarsal joint. So there is no direct connection between the base of the first and second metatarsal. The Lisfranc ligament isn't as it appears in these diagrams. It's actually very difficult to find a cadaveric specimen. I've got some MRIs that nicely demonstrated the yellow arrows pointing to the black Lisfranc ligament that moves from, that originates from the medial cuneiform inserting on the base of the second metatarsal. It is an interosseous ligament, as demonstrated by this cadaveric, a beautiful cadaveric specimen with the disarticulated midfoot joints. We're looking from proximal. On the right is medial, and we're looking at the proximal end of the medial cuneiform. On the left of that picture is the base of the second metatarsal with the Lisfranc ligament demonstrated between. It's the first time I've ever seen it, because whenever I explore this area, the Lisfranc ligament is usually ruptured. So it's the only connection between the middle and medial columns. I'm about to come on to the column theory. And it connects the base of the second metatarsal to the medial cuneiform. It's strong and it's wide. It is a substantial structure. So the column theory is a useful way of thinking around the functional anatomy of this area. The lateral column is between the fourth and fifth metatarsal bases and the cuboid. It is considered the mobile segment, and as such, it is necessary to never bridge or fuse this part of the foot, as there are multiple studies that demonstrate severe detriment to function. The middle column is the second and third metatarsal base and their respective cuneiforms, the intermediate and lateral, and this is considered the rigid part of the foot. It is necessary for propulsion and stability during propulsion. And the medial column consists of the base of the first metatarsal, the medial cuneiform and navicular, and is a semi-mobile joint. It's a rather unscientific term for it's somewhere between the lateral and middle in terms of its mobility. It has some, but not as much as the lateral. Considering the columns is useful when reconstructing these injuries, as they often fail together, they often move together, and it's important to consider the intercuneiform stability that can be as part of this injury when the medial and lateral columns move away from each other. So just a quick summary of the first few minutes of this talk. The shape of the tarsometatarsal joints, 2 and 3, they're wedge shaped and they form the transverse keystone in the transverse arch. The second metatarsal base is recessed within the cuneiforms and as such is often fractured during this injury. The weak dorsal ligaments fail preferentially, and the Lisfranc ligament is the only connection between medial and middle columns. Considering the functional columns is useful, they fail together, so you fix them together. The lateral is mobile, the middle is rigid, and the medial is somewhere between. So the mechanism of injury for these injuries, up to 2/3 are considered high energy as part of road traffic accidents. This may be improving with the improvements, or maybe changing with the improvements in road traffic safety and car safety. I work in a trauma unit. The polytraumas, high energy, tend to bypass us to the MTC. The majority of the injuries that I see are subtle low energy subluxation and sprains related to sports activity. I certainly wouldn't want to be playing American football against this chap. And the reason being is that if he lands on my foot in this position, it produces a Lisfranc injury. This is the demi-point position. The axial load produces or may produce an abnormal plantar flexion through the Lisfranc joint that then fails through the dorsal ligaments, then the plantar ligaments. This can be reproduced in a high energy collision, fall from a height. And so it's important to take the history of the injury and get as much information as possible, as that will raise the suspicion of injury. This is demonstrating a common source of our injury on the injuries that come to us on the rugby pitch, tackled from behind in a kneeling position, and the opponent, the tackler's weight is then forced onto the heel, loading the foot in an axial direction. So when diagnosing these, it's crucial to have an idea of the mechanism of injury, and that should raise your suspicion. Anyone who says they had severe pain in the midfoot at the time of an injury should be taken very seriously. There's some of these pictures, it's pretty obvious there's a midfoot injury, but looking for the plantar ecchymosis and palpating for midfoot pain is absolutely revealing and crucial when assessing these injuries. Plantar ecchymosis is not indicative of a Lisfranc per se, as many injuries do produce this phenomenon, but it is highly suggestive. Radiographs, the AP is used to assess the first and second tarsometatarsal joints. These are obviously abnormal. The oblique assesses the lateral 3 tarsometatarsal joints. And then the lateral looks at an overlay of all of the tarsometatarsal joints, but can be, in many circumstances, the only X-ray that's abnormal. It's estimated in historical series that 40% of injuries are missed on initial radiographs. I suspect it's not in the modern era quite as high as this, as we seem to have better education, but it is still missed, even despite our better systems around fracture management. We must all know what normal looks like. So on an AP, the lateral border of the first metatarsal is aligned the lateral border of the medial cuneiform, or the first cuneiform. Same X-ray, the medial border of the second metatarsal aligns with the intermediate cuneiform. On the oblique view, the third metatarsal base, the medial and lateral borders align with the medial and lateral borders of the third of the lateral cuneiform. It sometimes takes some imagination to reveal these, as there's a variation in projection. If that isn't obvious, then the fourth metatarsal medial border should align with the medial border of the cuboid. When drawing a line along the dorsum of the second metatarsal, it should align exactly with the cuneiform. Remember that the most proximal joint visible is the second tarsometatarsal joint, and any dorsal displacement is abnormal. Look for avulsions. This was a surgical practitioner in a minute injuries unit diagnosed this as metatarsal neck fractures with a os naviculare, when actually there's a clear widening of the space between the base of the first and second metatarsal with a cuneiform instability and a gap between the medial and intermediate cuneiform. The force of the fracture is then fractured through the navicular tuberosity. A high proportion of Lisfranc injuries have a fracture at the base of the second metatarsal. The flex sign is often seen. This is the avulsion of the Lisfranc pulling off from either the second metatarsal base or the cuneiform, and is a valuable diagnostic criteria. Displacement of more than 2 millimeters, so that's 3 millimeters or more, is considered abnormal. With high clinical suspicion, and if it remains with normal X-rays, then a CT scan can be either reassuring in that there are well-aligned, congruent joints with no fractures, or fractures that can be extra-articular. And the extra-articular fractures at the base of the metatarsals is something we see a handful of each year and can be managed non-operatively. If a CT scan is not helpful, then contralateral views, doing weight-bearing X-rays of both feet and comparing them to provide a comparison anatomy and radiological views. So if we're still suspicious, we bring our patients back a week later. By the time we've seen them, it's usually a week. And then we send them back a week later for a weight-bearing view. And this can be very revealing, as in this case, with an obvious instability demonstrated at this point. Stress fusion theatre. I had to take these X-rays, these pictures from a textbook, as our radiographers often forget to save ours at the end of the case. I tend to stress any midfoot under II that I'm planning on fixing before doing it. Just occasionally, I pick up an instability that I hadn't been aware of or hadn't been flagged up by the previous imaging. So I just want to labour the point that 3 views are required. There's something abnormal about these 2 X-rays, the AP and the oblique, but it's only when you see the lateral that it truly demonstrates the problem. So diagnostic pearls. Always consider the mechanism of injury, take plantar ecchymosis seriously, and the weight-bearing views is important, and it's important to know what's normal. But if it's not normal, or if you're still suspicious, then continue to dig deeper by lateral weight-bearing X-rays, or repeat the weight-bearing view, or repeat the weight-bearing view at around 2 weeks. CT is useful, and it's rare to take a Lisfranc injury to theatre without a CT. And an MRI scan has a role, but there are some limitations on access to this resource in most hospitals. Stress X-rays in theatre can make up your mind on your surgical strategy and reassure you that you are doing a necessary operation. I'm not going to dwell too much on the classification. I personally don't think it's a useful part of how I think about Lisfranc, but it is there. It is perhaps important for you to know for exams, although I believe it's not asked so much these days. Meyerson gave his name to the final version. It's descriptive. Some people says it helps them guide the operative strategy, although it has been shown it's not useful in establishing prognosis. So type A's are total incongruity. All 5 tarsometatarsal joints have been disrupted, and you can say whether they've gone lateral, dorsal, or planar or plantar. Type B's are partial incongruity, and these do illustrate to me the importance of looking for the intercuneiform instability. Then there's the divergent pattern. I've only seen one of these in my 7 years as a consultant, and there are various subtypes. So treatment goals is to attain a painless, stable, plantar-grade foot and to use normal footwear. The current series support requirement for anatomical reduction, and how you achieve this anatomical reduction is an area of some controversy. The outcome is absolutely reliant on the quality of your anatomical reduction and the stability of your reduction. If you get a good anatomical reduction, you have the chance of achieving good functional and symptomatic results, up between 50 and 90%. If you have a poor reduction, that drops to less than a third. So the treatment options. So you've identified an injury, but it's undisplaced and it's stable. It is reasonable to consider a below knee plaster of Paris for 6 weeks, non-weight bearing, and then rehab for a further 6 weeks, working up to full weight bearing. But this is uncommon. The undisplaced but unstable, or the displaced, there is very good evidence that there's very poor outcome without operative management. You either fix it or you fuse it. And I find this kind of reassuring. If I do nothing for these injuries, they do badly. So I have an opportunity to influence in a positive way their future. Always consider the soft tissues. If you have a severe dislocation with threatened skin, tented skin, bones palpable and close to the skin, then an urgent close reduction is required. They all need to elevate, and then you come back when the soft tissues are settled for definitive operative fixation. There are some options when considering how to fix these injuries. The current feeling amongst the foot and ankle fraternity and maternity is that the Lisfranc screw, the bridge plating, is the way to go, with K wires for the fourth and fifth, which can be open or buried. And this is indeed reflected in, this is the extra preference and my preference. Historically, the Lisfranc screw with the transarticular screws was very much the way to go. There's been a recent meta-analysis, and it is suggestive that bridge plating has some advantages over transarticular screws, although the evidence isn't completely conclusive, and further research is required. There are a couple of operative interventions to consider. I have no direct experience with the Lisfranc tightrope, but there are case reports, and I have heard of its use in high-profile sports people with partial sprains or strains to enable them to return to training. But it's an area that without a strong evidence base or experience. External fixation is not something I've ever had to consider, but it may be required for severe soft tissue injuries, open fractures, and I think this would be a reasonable construct to use. It would be important to place pins, a calcaneal pin, transverse, and then a distal pins in the metatarsal away from any zone of injury or operative fixation. So approaches, the standard textbook approach is through an incision on the medial border of the second metatarsal, allowing access to the first, second, and third tarsometatarsal joint, with a supplementary lateral approach if required. There's been a move away from prescriptive approaches. My preference is to place a central incision over the second metatarsal shaft, and this allows access to the Lisfranc area, the Lisfranc ligament, the second metatarsal base, and also the third metatarsal base. And this, for many of the injuries that I see, is adequate for what I need to or wish to achieve. If I need access to the first tarsometatarsal joint, I'll place a separate incision over the dorsal medial aspect. And this is my colleagues and I have found this to be a reasonable approach, and we've not had significant wound complications. If we do need to access to the lateral column, then a supplementary incision can be utilized. It's very rare to need this. So some relevant anatomy and planning approach. The dorsalis pedis and the deep peroneal nerve is situated between the extensor hallucis longus and the extensor hallucis brevis tendon. When placing an incision coming down on the lateral border of the extensor hallucis brevis, it is then reasonable to use this to protect the neurovascular bundle and allow access to the base of the second metatarsal and also the interval between the base of the first and second metatarsal. Here's a clinical photo of it in action, and that's the second metatarsal base exposed. The neurovascular bundle is protected medially with the homen, and you can just see the belly, muscle belly of the extensor hallucis brevis. So some operative tips. I tend to mark my incisions with the X-ray first. I feel it prudent, but this is just a personal preference. The use of the radiolucent triangle is very useful for gaining an easy AP without having to move the foot around. It just needs to then rotate the leg internally to get an oblique. Use of K-wires to transfix the the joints in place prior to intervention, bearing in mind that placing the K-wire just off to away from where you're about to instrument is usually advantageous. Placing the Lisfranc screw, it's often placed from medial to lateral through the medial cuneiform into the base of the second. It can be quite difficult to pass a cannulated screw wire in that direction, and I would advocate considering passing it from lateral to medial, drilling the hole, holding the reduction with a clamp or another wire, and then placing the screw over the wire that comes out through the medial skin for easy retrieval. So, direction of the Lisfranc screw is demonstrated thusly. And then rehabilitation involves 2 weeks in a splint with removal of sutures. We use nylon sutures universally, and a further 4 weeks, so 6 weeks in total, non-weight bearing. Range of motion is commenced at 6 weeks, and touch weight bearing working up to full weight bearing by the 12-week mark. They then have rehabilitation with our physiotherapists and in our hydrotherapy pool if required, and we meet again at around 6 months to discuss the issues of metalwork removal. This is relatively controversial. There are some, I would definitely in younger patients advocate it, as I have had some very symptomatic patients when they had their metalwork in who were delighted when the metalwork came out. But it's I tend to have a conversation with the patient, talking through the ins and outs. You may have I may damage the deep perineal nerve when I take this out. It may not make a difference to your symptoms, and we make an informed choice together. So before we stop for some questions, I just want to introduce a paper from Chris. Now I always get his name wrong. Coetzee, I think is how you say it. Who 15 years ago did a remarkable randomized controlled trial comparing Orth with primary arthrodesis or primary fusion for pure ligamentous Lisfranc injuries. And he had 20 and 21 patients in each arm, and he showed a significant functional and outcome advantage in the fusion group. And I would recommend wholeheartedly the webinar that you can find on the BOFAS website, hearing Chris Coetzee talk about this, as he has some really insightful statements around this issue. But it's considered that if you have a purely ligamentous injury, that a fusion probably has advantages. You don't have to remove the metalwork, and I've never regretted a Lisfranc fusion. It's probably indicated for severe soft tissue injuries, as you don't want to go back in to take the metalwork out, to potentially have to go back in again to fuse the joints. And it's potentially indicated for the severe bony injury that's damaged the joints beyond salvage. It's probably indicated for delayed presentation. And occasionally the older patients, it might just be better to give them one operation rather than the removal of metalwork and then the need for an arthrodesis at a later date. So in summary, fixed, displaced or unstable injuries, there's very poor outcome with non-operative management. Outcome directly related to the quality of reduction. Incisions and operative strategy are directed by the injury pattern, and consider primary fusion when planning surgery and treatment for these injuries. So I'm going to take a little drink there. And I don't know, I haven't been looking at the questions.
Adrian, hi. Thank you very much indeed. What a great tour de force and run through of Lisfranc injuries there, covering all things. It really is quite a devastating injury, but you get it right and you fix or fuse, and I, same as you, and it can make for a really good plantar grade and comfortable foot long term. Great lecture, thank you very much. There are a few vet questions come through. So if we what I want to do is break them down to the beginning of your lecture and then come through to the more esoteric stuff at the end. Just to, again, reiterate the question here, in the diagnosis, what do you see as those key investigations that you get as a matter of routine when looking at these?
I think it's unusual not to get a diagnosis from plain X-rays, but I think a weight-bearing X-ray and considering bringing them back 7 days later, if you're really suspicious, can be very enlightening. I have had some patients where I've been so suspicious that we kept bringing them back. They had a CT until we demonstrated, and then it took an MRI scan to say, actually, yes, they did have that Franc injury. So it's for me, it's the index suspicion driving that investigative and that diagnostic ladder, if that makes sense.
A question here. What is, just to break it down a little bit further, how do you determine the stability of it?
Well, the stability is demonstrated by the weight-bearing dynamic X-ray and the separation of the first and second metatarsal bases usually on the AP, but it can occasionally be seen on the lateral. And I have had one patient where I suspected they had a dynamic instability chronically, and a single stance X-ray view where a patient is termed a stalk view. So a patient is tucked one leg up like a stalk, standing fully weight bearing on that one X-ray, was then diagnostic in that individual. So I'm not advocating that for every patient, but I think it's working up, as I say, that diagnostic ladder. But defining the instability is on the weight bearing loaded view and the separation of the base of the first and second metatarsals.
That really is kind of the more subtle ones there, because when they're really gone, they're gone, aren't they? Like some of the one you show on Chris Kurtz's paper. You can always, you just say it from the plain X-rays, can't you?
Yeah, yeah.
Okay. Now, what for consultants who are not foot and ankle, what would you expect of them in the middle of the night or on a general trauma for a fracture dislocation?
Usually our ED guys will reduce a dislocated midfoot. But on weekends, we would expect our non-foot and ankle guys to take threatened skin and poor position on X-ray to a theatre and reduce. But saying that, I have a couple of cases that illustrate why occasionally that's difficult, because the reduction can be rather challenging because there can be interposed tendons, bone fragments, bits of ligaments that can block the reduction. But most of our general orthopedic surgeons on the rota are comfortable reducing fracture dislocation.
Okay. And then basically then we now move on to the kind of more surgical side of it. One question is, do you change your approach now then between somebody who has a pure ligamentous injury over somebody who has a bony Franc injury?
I've definitely, in the last 7 years, I have started to fuse more patients. And I think on the basis of those purely ligamentous, if I look back, those purely ligamentous, haven't had many come back, but the one or two that have were perhaps should have had a primary fusion. And I've never regretted doing a primary fusion. When I've gone in and I've seen the joints absolutely destroyed by the injury, it makes perfect sense to fuse it. And those patients do really well. It is a compelling evidence of Chris Kurtz's paper to consider the fusion. But in younger patients, in the younger athletes that's got really pristine joints, but they're dislocated, it is quite a brave decision to do that. And so, but I think it is probably the right thing to do.
Yeah, I often will send patients to go and read that paper. And that, as you say, shared decision-making, isn't it?
Mm.
There's a couple of questions here related to that, actually. So in a pure ligamentous injury in young athlete, any role for autologous Franc ligament reconstruction? So harvesting ligament and putting it in. I've not seen that personally. Have you an experience with that?
I have no experience. It's a nice idea. I have no experience of that. It sounds, yeah.
And have you ever used tightrope or any place for tightrope in a pure ligamentous injury?
So I have in our unit we have had one in a high profile, well, an elite rugby player who returned to training and is still 4 years later playing high-level elite rugby. But it's yeah, I have no direct experience. I know it's out there, but I don't know if that's a thing or not. And probably in the future there will come some series from those individuals who have really big sports foot and ankle practices that would suggest it may or may not be a good idea.
Questions here about fusions. If you're fusing a whole Liz Franc, which joints are you fusing? 2 and 3 or more, or all that are necessary, or do you preserve any of them?
So I preserve any that are stable and uninjured, and that can mean the last few I've done have just been 2 and 3. In fact, the last one was just 2. But if there's the importance of the preoperative investigations and analysis, looking for the congruity of the tarsometatarsal joints, and also of the screening at the start of the case when in theatre with the X-ray machine, the anaesthetized patient, because occasionally you don't think the first is unstable and it becomes very obvious it is. But that's what I would be fusing. I'd be fusing the joints that have been demonstrated as unstable, but never fusing the 4th or 5th tarsometatarsal joint.
A couple of other questions here. In your practice, would you consider a primary fusion if patient presented late or fixation, regardless of duration since injury?
Yeah, that is one of the indications, the late presentation. Had one recently, he was about 4 months from the injury, and our consensus view that he got a fusion of the 2nd tarsometatarsal joint.
And the question here, what do you use for your fusions?
So again, Chris Coates here, a great statement that you have to do an in situ fusion. So it's maintaining as much bone stock as you can, and avoiding using a saw or a burr, using the osteotomes or curettes to denude any remaining cartilage, and really just breaking down the subchondral bone so that you're really doing an in situ fusion in the right shape. Because what you don't want to do is deform through the midfoot, producing problems with the forefoot. And that's especially true for the first tarsometatarsal joint. One of the most difficult elective operations I do is a lapidus, and due to the difficulties around balancing the position of the first metatarsal head, and a fusion in Liz Franc can be really challenging if you've lost bone. But usually there's enough so that you can gain the correct shape where the first metatarsal needs to sit.
Questions here that are kind of linked, again, recovering things. In the case of severe swelling, is it wise to start with pinning and then orif when skin permits? And there's a question that follows on with that. How long would you wait for the skin to settle down?
So start with the second question first. I wait as long as it needs to, until the skin is obviously wrinkling, starting to settle. Blisters I deliberately de-roof blisters to allow them to epithelialize. And I have waited up to 4 weeks. Usually it's around 2 to 3 weeks. I didn't quite catch the first question. It was around pinning. Does that mean using an X-fix? I've never had to or considered using an X-fix, but I think I would if there was severe soft tissue, either loss, an open fracture requiring plastics reconstruction, or indirect direct damage at the time of injury. So providing skeletal stability in the right kind of shape while the skin settles to enable me to perform definitive fixation. I hope that answers the question.
It does perfectly. The question here, why put them in a back slab after your surgery? Why not straight into a below knee cast from the beginning?
A couple of reasons. There's instances of swelling after the surgery, and so a back slab is really just to maintain a plantigrade foot. You're not providing support for the bones. That's all done with plates and Liz Franc screw. You're providing support for the soft tissues. And so it's soft tissue recovery. maintaining a plantigrade foot so they don't develop an equinus problem. But I would be uncomfortable putting a full plaster on in theatre, and also its speed. Once I'm done with this, I need to get the plaster on, a safe plaster, because it is important to take care of plaster applications in anaesthetised patients. But it's much quicker for me to put a back slab on than a full plaster.
We've got one last question here before I know you've got some cases. Would you do anything different in a Charcot type Lisfranc fracture dislocation?
Yes, I would. And that's slightly beyond the realms of this talk, but a Charcot midfoot is a very different kettle of fish, and it's a whole talk in itself, actually. But in principle, if I was going to fix a Charcot fracture dislocation, I would use significantly bigger plates. I would probably do intra-articular bolts and beams. I would prep joints. They're usually in diabetic, so I'd do a tender Achilles lengthening. And the strategy is very, very different. And it's a very good point, actually, in that recognizing the Charcot Lisfranc it's a completely different beast and needs a very different strategy.
Adrian, thank you. You mentioned you did bring some cases. If you wanted to share your screen and go through those, that'd be really kind.
Sure.
While you're doing that, just to point out to those listening, in the chat function right now is the code for feedback. So do pick that up for your CPD later on, and please for the feedback. And perfect. So you're just coming up on screen now. That's great. Thanks, Adrian.
There we go. Okay. So first case, it's a 58-year-old. She was on a night out wearing rather substantial heels, and she fell off them. And she presented with this grossly deformed foot. And apologize, I don't have any clinical photos and these X-rays. ED decided they were busy at 2 in the morning, and so my colleague, who is a non-foot and ankle surgeon, was greeted with this this morning. He correctly analysed that really the first tarsometatarsal joint is completely incongruent. Can you see my my arrow there, Tim?
Yeah, we can see that fine.
Yeah.
So
the first tarsometatarsal joint is completely dislocated. The base, the medial border of the second metatarsal, which should line up here, is a good centimetre or two across, and on the oblique, the medial border of the fourth should line up with the cube, and it sort of does, but it all looks completely abnormal around here. He'd also noticed that there's an increased space here. He was worried when he saw this patient on the morning ward round and decided by her skin. And so he decided that he was going to take this to theatre and reduce it. And unfortunately, it was irreducible. So I happened to be at the rugby with Ian and Nick, and I was the designated driver. So when we picked up the phone, it was my turn to go in and help out a colleague in need. So I didn't have the usual of a CT scan, and so my analysis of this is that it was both the medial and the middle column, and probably the lateral column was okay, but it all rotated, and it all rotated dorsally and laterally. So my operative strategy was to open this through at that point, this was a few years ago now, I did a incision over the the medial border of the second metatarsal, opened it up, and the extensor hallucis tendon was incarcerated within the Lisfranc, where the Lisfranc ligament should have been, so it was wrapped around the base of the second metatarsal. That's me reducing the first tarsometatarsal joint, placing a K-wire to hold it in place, and then the clamp is along the direction of the Lisfranc ligament, or where I imagine the Lisfranc ligament travels. And so I've reduced the base of the second into its recess, and actually the rest of the joints all then reduced. But I looked, looking at the intercuneiform joint, I could pass the McDonald right through it, and I decided therefore the fixation was going to be my Lisfranc screw, then an intercuneiform screw, and then a dorsal bridge plating. So I've sort of got some control of this now, with the second metatarsal base reduced, the first in place, and then I went on to plate and bridge plate the second and third. Now, looking back at this was some x-rays that she had a few months later, and she actually did very well. She was lost to follow-up, as she was a little bit of a bon viveur, and she then came back and had her metalwork out about 18 months ago. One of the screws had broken. That was 4 years ago, and I haven't seen her since, maybe because she doesn't like me. But if I'm critical, I think in hindsight, and if I'd seen this injury now, I would probably, in this patient, in this age group, with this, what was really a pure ligamentous injury, I would do a primary fusion.
Would you have attempted that primary fusion there and then, or stabilized it to that acute episode and waited?
Well, that was the challenge. Is I was going in a bit cold, and because I was, I'd been drafted in at the last minute. So I think I made the right decision at that moment.
Oh yeah.
And I think on if I'd had the time, I would have. I now consent all patients for a fusion and fixation, and I tell them that I'm going to do what I think is right at the time, and we talk about what I'm likely to do. And for this patient, I would have probably said I'm likely to fuse these joints, but she's actually done okay. So and this is part of the difficulty in the unpredictability and unpredictability of outcome. So shall I move on to a?
Yeah, go. Excellent.
So this was a 73-year-old who fell over in the garden. Relatively fit, 73-year-old, independent living, community dweller, non-smoker. And this is one of my colleagues' cases, but he really felt that he wasn't quite sure about the first on these x-rays. He's certainly got some hallux rigidus and some first MTPJOA, but certainly the second and the third are not where they're meant to be. If we draw a line down the medial border of the second metatarsal, it really should be across here. And similarly, the third should be somewhere in here. So it's very, sorry, this one, it's very difficult to understand these x-rays. And on the lateral, the most proximal tarsal metatarsal joint, the second is dorsally displaced. And the CT demonstrated quite significant comminution at the basis of the second and third, but actually a congruent first tarsometatarsal joint. So my colleague screened the first and decided it was stable. And this patient was going into this operation to have a primary fusion. The age group, the comminution, and the degree of damage of the joints, we felt it was in their best interests. So the operative strategy was to use a wire just off center, but securing the bone in place and prepping the joint, leaving as much of the native bone as possible, really just breaking down, taking off the remaining cartilage and pettling or breaking down the subchondral bone. Plate fixation, and this is a compression plate with locking screws proximally, a compression screw, and then locking screws distally. Then addressing the third, and when he, in the similar fashion, when he'd done that, the fourth and fifth were congruent and stable, and he screened them, and he elected not to put K-wires in at that point, but it's not unreasonable to. And if we do, we tend to bury the wire. We've had some problems with infection around wires out through the skin and the foot. And so we tend to bury the wire and can retrieve that 6 weeks later with a short general anesthetic. This was them. This is them 6 weeks after their fusion, and they went on to a reasonable outcome.
With your wires, do you let them walk on it at all before you take the wires out the fourth, fifth, or do you tend to get those out prior?
No, we would leave them in a plaster so back slab for 2 weeks, then into a plaster at 2 weeks until 6, and then at 6 weeks at the plaster change, we'd arranged a short anaesthetic and a retrieval of the wire.
And a question just come through: when you're doing your fusions here, do you use any cancellous or graft or bone substitute graft to maintain bone stock?
It's unusual for us to. We definitely don't use any bone substitute. We occasionally, if we need to, and if there's big gaps or big defects, but that's not been my experience that that's a common occurrence. But if we do, then we'd take it from the calcaneum.
Yep, it's a nice little place to go to, isn't it? Good bone from there. I agree. Excellent. Next case. Good case.
So this was a 20-year-old student. She's a keen netball player and a good netball player, and she landed, and she describes quite elegantly landing on her tiptoes, and then her foot gave way, and she couldn't play on, and she could barely walk. She came to Franc's clinic at 7 days. She'd had these X-rays 7 days previously. She had a distinct and vivid plantar ecchymosis, and she still couldn't walk. So she was sent round for a weight-bearing X-ray, and she was sent back, and they couldn't take the X-ray. She couldn't tolerate it, and that for us really heightened our suspicion. We got a CT scan, and this is the only view that really showed any incongruency. So the question is, what do we do now? We're now at day 10. We considered getting an MRI scan, but at the moment getting MRI scans for us is just impossible. So we took her to theatre, counselling her to the fact that we were going to open reduce and fix her second metatarsal with a Liszt Franc screw if we demonstrated instability on a stress view. Unfortunately, I don't have but she was unstable, and but she was unstable only through the second, and we then put the Liszt Franc screw, and she's done reasonably well as well. So important. These are, if I can go on to the next one, there's in fact, while we're on a roll, I just want to, that's much of the same. So, and just the last case, just to illustrate what happens if these are neglected. This was a 34-year-old builder. He had a heavy tackle playing football, and he presented at 2 weeks. Rather suspicious looking examination history and x-rays, as he was having difficulty walking with midfoot pain. He had some weight-bearing x-rays and a contralateral, it's the left side that is injured, which really weren't that helpful. But my colleague, this is one of Nick Talbot's cases, was so suspicious he's arranged an MRI scan, which showed there were just a complete absence of the Liszt Franc ligament. Now this gentleman, he then came back to my clinic with the MRI scan. We prepped him for surgery, and I walked out to get the iPad to consent him, because we've got an electronic patient record. And he then decided he didn't want surgery because he was getting divorced, he needed to work, he was leaving his wife. So he elected not to have surgery against our judgment. And he came back 4 months later, miserable, unable to walk, with this separation of the second and first tarsometatarsals. So there's an obvious winding, and we decided was the best. It was best served with a fusion. And oddly enough, when I did the fusion, he had instability between the cuneiforms. So
get it wrong, and it can go wrong, can't it?
That's right.
Fusion does get you out of it. Look, we've got time. There's one last question here, if you wouldn't mind, because we're nearly at 9 o'clock. Quite an interesting one. Are you able to talk through how you do a stress view in theatre?
So I position the patient over the radiolucent triangle, as that photo demonstrated. I grab the heel with one hand, or the hind foot with one hand. I grab the front of the foot with the other, and it's kind of difficult for me to, but I essentially move it. No, it's not going to work, is it? I essentially move the foot like this.
Yeah.
And that tends to demonstrate any first TMT instability. If I then grab the foot like this, I then try and pop the second tarsometatarsal joint out of joint, and that's quite difficult to demonstrate on an X-ray, to be honest. So it's not a precise science, and I don't think I'm probably the best at it, but I try.
I think we're going to leave it there. Adrian, that's been fantastic. A great session and covered all things. Thank you very much indeed. And thank you for contributing to the BOFAS Lectures of Distinction.
Thank you very much for having me.
So there we have it. So first of all, just to mention again, then the feedback code is in the chat. You're going to see a QR code soon, which will give you access to getting your CPD points. Also then to mention that next week, we've got really privileged to have Deborah Eastwood from Stanmore Hospital talking on gait analysis, which is something that's key for the exam, and actually something that we, as you get more experience, you realize how important it actually is. I'd absolutely recommend you try and join us for that. But then we've had Adrian Hughes talking on the Liz Franc, and really key messages are to recognize the injury and do something about it. Look for and assess for stability. If it's unstable, it's almost indicative that you've got to do something. You can manage it temporarily and wait for those soft tissues to settle. And then there'll be the debate about whether you're going to fix or fuse. But most key of all is try and get that anatomic reduction. And that's been shown to give you that really nice result. So hopefully you found that valuable, and thank you very much for joining us. It just leaves me to say on behalf of Adrian and myself and the team, thank you very much and good night.
My name is Andy Jones. I'm the CEO of Ramsey here in the UK. Ramsey Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsey Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsey hospitals to refer their patients for high quality healthcare. So Ramsey has got a long-standing set of values called the Ramsey Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsey Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsey, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.